Palpation of chest. During palpation will determine elasticity of chest. For this purpose, we'll press chest in both directions, anterior, posterior, and then later on. Our conclusion will be chest is elastic because during pressing it slightly moves inside. Next palpative method is vocal prematus. Patient must ask loudly what's with letter R. It can be red, right. Our patient asks 3. Anteriorly, we'll put our hand above clavicle, then below clavicle. Position of doctor must be to the right of patient. Firstly, above, and then below. Lateral side, we'll ask the patient put his hand on head. Put our hand deep in armpit, then lower. At the back, turn the patient, and patient must connect his elbow. That scapula moves outside, and we'll put our hand above scapula, then between scapula such that 8 of palm will be near the 8 of scapula, not near the spinal cord, near the scapula, and then below the scapula. In all cases, patient loudly asks what with letter R. Next palpative method will determine subcutaneous fat. For this purpose, you take horizontal fold under the scapula or on muscle. The thickness of fold cannot exceed 1.52 centimeters. If more, it indicates obesity. If smaller than half centimeter, it will be cachexia. Then, with palpation, will determine epigastric angle. We'll put thumb finger on rib arch, such that it will be connected near the xiphoid process, and determine size of angle. In our patient, it's near 90 degrees, which indicates nomoscenic chest. Percussion, comparative percussion. In front, above clavicles, then on clavicles, then below clavicles, along mid-clavicular line. Finger must be placed in interspace and will finish on the level third interspace, because lower heart we cannot compare heart and lung. On side, again, patient put hand on the head and will make percussion along mid-axillary line. At the back, patient again connect his elbow. We'll start percussion from supra scapular fossa, then along scapula, finger near the scapular angle, not near the spinal cord, and then under the scapula. That's all. Topographic percussion, when we'll determine position of apex in front. Direction of our finger must be parallel of clavicles, not on the neck, because inside neck absent lung, not to the back, only parallel of clavicles, and we'll move very slowly. Sound change, will make mark, and then measure distance with scale from clavicles to our mark, and give conclusion about position of lung apex. At the back, we'll again percuss from spinal scapula, and position of our finger also parallel spinal scapula, not to the front, not to the neck. Gradually percuss. Sound change, will make mark, then ask the patient incline head, find more prominence vertebra, it's 7 cervical vertebra, and compare our mark with position 7 cervical vertebra. Topographic percussion is made along all topographic line from parasternal line. Parasternal line is situated between sternal line, we'll find 8 of sternal, then mid-clavicular line. Between both line will be parasternal line. We'll percuss from clavicular downwards. Finger is placed in interspace. Sound change will make mark and then calculate rib from clavicular, first rib, then second, third, fourth, fifth rib. Our conclusion, lower body of lung along parasternal line on the level fifth rib. Same along mid-clavicular, along anterior axillary, medial, posterior. When we'll determine body of the lung at the back, will not be percuss over the bone. We'll start from angle of scapula. Sound change will make mark one. And then calculate rib from angle of scapula. Scapula covers 7 rib, lower will be 8, 9, 10. Position of lower body along scapular line on the level 10 rib. Also along paravertebral line, it will be between spine of vertebra and scapular line. This is. And we can calculate position from angle of scapula, or if patient with obesity and very difficult to palpate rib, we can calculate on the vertebra. It's 7 vertebra, then will be first, second, third, and continue before our mark. It should break. Scapula moves and angle of scapula also moves. It cannot be scapular line. Only during auscultation and comparative percussion, because we must open lung. Topographic percussion will make below angles of scapula, and it's not needed upper part of lung for topographic percussion. Will determine position of lower lobe, then upper lobe and upper lobe. When we listen additional lung sound, we'll ask the patient breathe through the nose, because we must listen main respiration, usual respiration. If the patient breathes actively through the mouth, he artificially intensifies breathing, and breathing cannot be known. It can be harsh, or we can simulate in some cases pathological bronchial breathing. But we won't reveal normal breathing, which is typical for our patient. Patient breathe usually through the nose. Then we'll put stethoscope in symmetrical point along topographic line, anteriorly along mid-clavicular line, lateral along mid-axillary line, at the back around the scapula. When we auscultate patient anteriorly, firstly supraclavicular fossa, then subclavicular fossa, before third rib, because we cannot compare heart and lung. Then lateral side, patient put hand on the head, we'll put stethoscope deeply in armpit, then lower, and one hand of doctor must be on the back of patient, because we prevent suddenly falling of patient, because patient can be afraid, or if patient longer breathe actively, it can be artificial hypoxygenation of brain to prevent traumatization of patient with slightly false operation. At the back, during auscultation, patient again cross his hand, and we'll put stethoscope near the scapula, firstly above, then around the scapula, near the angle of scapula. Our conclusion will be over lung, symmetrical vesicular breathing. When we auscultate additional lung sound, principal auscultation same, position of stethoscope same, will only give the patient new command. Patient must breathe actively through the mouth, because we can provoke additional sound that they better will be heard when the patient actively breathes, because is needed active passage of airflow. Because murmurs is turbulent movements of air in case of dry rails. In moist rails also is needed active movements of air to provoke formation of bubbles, which will be heard as moist rails. For revealing pleural friction sound also is needed active breathing, because during active breathing more actively fricts one layer of the on pleural to other, and we more better heard additional sound. That's all respiratory system. Cardiovascular system. Cardiovascular system palpation. During palpation, we'll determine apex beat. For this purpose, we'll put our finger along anterior axillary line to the left, such that third finger will be along 5th interspace, second, fourth, 6th interspace, and palm also must be tightly placed to the chest. If the patient with normal constitution, physiological constitution, 5th interspace usually on the level of nipple, and we put our third finger under the nipple. Then we'll gradually move finger along interspace before feeling pulsation under finger. I feel pulsation under third finger. I can determine situation of apex beat. Apex beat is situated in 5th interspace, 1 centimeter medially from left midclavicular line. Then I'll determine its width. I feel pulsation under one finger in 1 interspace, but then I'll turn finger along interspace. Again, I feel pulsation, in our case under both fingers. It indicates that apex beat is diffuse. If I feel pulsation in 1 interspace and only under one finger, it will be restricted apex beat. In our patient, apex beat diffuse, because I feel pulsation under 2 fingers. And if you attentively see on my fingers, you see that my fingers moves together with apex beat. Yes? It is high apex beat. If my finger was unmovable, apex beat was low. Its next characteristic of apex beat is highest. In our case, you see that my finger moves together with apex beat, high apex beat. And I can say that it has moderate force, because I not feel significant trough of the chest. And if you attentively see on the chest, you can see that apex beat in our patient visible. visible. It can be in patient without subcutaneous fat, patient with a thin constitution, and we think about no because apex beat is visible medially from left midclavicular line. If laterally, it can indicate hypertrophy of left ventricle. During palpation, we'll determine vibration of chest, systolic and diastolic. Diastolic vibration appears due to mitral stenosis. To its determine, we'll put our hand on the area apex beat. If we feel vibration, will be positive cat's paw symptom. If we don't feel vibration, we say that diastolic vibration absent or cat's paw symptom negative. Systolic vibration appears in patients with aortic stenosis. We'll put our hand along the sternum on the areas of aorta. Conclusion also present or absent any vibration. Percussion of heart. During percussion, we'll determine two bodies, relative two bodies and absolute part of heart which not covered with lung. Right body of heart, Firstly, we'll determine relative dullness. Is needed to determine position of lung or diaphragm, sound change, its position of diaphragm. Then we'll rise on one rib, turn our finger vertically, and then gradually percuss to the sternum. Sound change, I'll make mark and compare mark with 8 of sternum. For this purpose, I'll palpate first interspace. I feel 8 of sternum and then moves along 8 of sternum. My conclusion, right body relative cardiac dullness ½ centimeter laterally from right 8 of sternum. If is needed determine absolute cardiac dullness, we'll also determine position of lung, rise on one rib, percuss before first changing of sound, without mark continue percussion before next changing of sound. Sound change, I'll make mark, and again find 8 of sternum. Now is needed left 8 of sternum. I see that right body of absolute cardiac dullness is situated on the left 8 of sternum. Upper body is determined along parasternal line between sternal and mid-clavicular, and will percuss along interspace. Sound change, I'll make mark and calculate rib first, second, third. Upper body of relative cardiac dullness, lower 8 of third rib. If is needed absolute dullness, will continue without mark. And again calculate rib first, second, third, fourth rib. Absolute cardiac dullness, lower level of fourth rib. Left body must be started from palpation of apex beat. Firstly, I palpate apex beat. I find that apex beat is palpated in 5th interspace, and then I'll percuss along 5th interspace. If apex beat impalpable, we also percuss along 5th interspace. But in all cases, we'll start from anterior axillary line. Vertical position of finger. Sound change, will make mark and compare with position of mid-clavicular line. Left body relative cardiac dullness 1 centimeter medially from left mid-clavicular line. Is needed absolute, will continue. Sound again change. Again compare with mid-clavicular line. Absolute down is 2 centimeters middle of left mid-clavicular line. Position of vascular bundle. We find second interspace. And start percussion from mid-clavicular line to the sternum. We'll make mark. Then we'll percuss to the left, again find second interspace. Sound change, again make mark. And then I'll compare my mark with position of sternal 8. I'll find 8 of sternum. And I see that my mark along 8 of sternum, our conclusion will be position of vascular bundle along right and left 8 of sternum. Normally they can be along or slightly inside. Order of auscultation. Firstly, we'll auscultate mitral valve, its position of apex valve. Then aortic valve, second interspace to the right of sternum, immediately near the sternum. Then pulmonary trunk, second interspace to the left of sternum. Then tricuspid valve, xiphoid process, slightly to the left. If we reveal any pathology over aortic valve, we will auscultate additionally Botkin air point. It's junction of third, fourth rib with sternum. First position of stethoscope on the heart apex. Next position, symmetrically, and tricuspid. If is needed Botkin air point, we restore to third, fourth interspace to the left. Our conclusion must include information about cardiac rhythm, rate, loudness sounds over apex and xiphoid process where fourth sound is made, then loudness second sound over heart base, information about accent. We must compare second sound over aorta with pulmonary trunk. Then we'll determine clearness of sound. If we listen sound as short stroke, we can say that sound clear. If we listen widening or instead one sound two short stroke, will be splitting or reduplication. And if we reveal any additional sounds between main sounds, we can think about murmurs, systolic or diastolic. It will be full conclusion. Position of patient on the back, and his knee must be slightly bent to relax. Superficial palpation. We'll start from question to the patient about pain. If pain absent, we'll start palpation from left iliac inguinal region and then symmetrically all 9 regions of abdomen. If patients have any pain, we'll start from areas which is far from painful area and finish with painful area. Now, if our patient without pain will palpate left iliac inguinal region, and during superficial palpation, all hands must be tightly placed on abdomen and will work only with finger. One movement, only one movement. It's not needed make such movement or such. Only one, tightly place and then slightly bend and relax. First left iliac inguinal region, then right iliac inguinal region, left lateral side, right lateral side, left hypochondrium, right hypochondrium, epigastrium, umbilical and suprapubic. Our conclusion, abdomen is soft, painless, without hernia and tumor. Deep palpation, we must show 4 movements. Position, then fold, We'll move only skin without deepen movement. Then we'll ask the patient breathe with abdomen. And during expiration, abdomen moves downward and our hand also gradually dips inside the abdomen. We can make 2-3 movements. It will be depend from thickness of subcutaneous fat and from tension of abdomen. Is abdomen soft? Sufficient 2 movements. If abdomen enlarged and firm, we can give 3-4 movements. When the finger, as possible, deeply dips inside the abdomen, then during next expiration, we'll make sliding movement. During sliding movements, our finger moves through the intestine because intestine resembles cylinder. We'll put finger above the intestine, then fold, deep in movements, and then slide through the intestine. And we can feel its size, consistency, any roughness of surface, pain, and other properties of it. We will palpate sigmoid. Sigmoid lies slightly inclined direction, parallel of iliac bone. We'll put our hand along course of intestine. This is position. Then fold, breathe with abdomen. Then I'll give 1 deep in movement. Then next deep in movement. And then during next expiration, I'll make sliding movement and remove my hand. Such principle secant. Position, fold, deepen, sliding movement. When we'll palpate ascending and descending part, bones absent. And absent walls to which can be pressed intestine. We'll build artificial wall from left hand by manual palpation. One hand near the side, right hand along course of rectus muscle, position, then fold, then deepen movement, and then sliding movement.
For ascending is slide, ma'am, towards the hand.
Sliding movement outside. We press the intestine to the hand.
To the hand, yes.
To the hand. But fold will be opposite side.
Yes.
Descending part also will build artificial wall. Put right hand along course of rectus muscle, make fold, then deepen movement, and then sliding movement through the intestine. All movements must be slow and careful. Then we'll palpate stomach, large cavity of stomach. For this purpose, firstly we must determine position of large cavity. We'll put stethoscope on traube space above rib arch. And right hand make friction movements along linea alba. When sound disappears, we decide that it's position of stomach, and we'll put our finger on this level. Normally it must be 2 centimeters above navel. We can palpate large cavity of stomach with 2 methods. If the abdomen is soft, we can palpate along linea alba. Third finger will be placed along linea alba. Position, fold, then deepen movement, and then sliding movement. We'll feel elastic fold from which our finger moves. If the abdomen firm, we can palpate large cavity slightly laterally. Put finger laterally, and position of finger must be inclined. Move to the edge of catchment. This position will be because stomach moves such. And again position, then fold, then deepen, and then sliding movement will be. After stomach, we'll palpate transverse colon. Transverse colon lies usually. Transverse colon lies 2 centimeters below the stomach. If we'll determine stomach 3 centimeters above navel, transverse colon on the level of navel, its normal position. If stomach downwards, transverse colon also downwards lower. We'll put both hands simultaneously such that third finger will be along course of rectus muscle. Next finger on one line. And we'll make fold, then deepen, and then sliding movement.
Fold, dipping, sliding.
Fold upwards, ma'am.
4 movements: position, fold, deepen, sliding movement.
Normally, we along the navel line, right?
Along the level of navel normally. Intestine. Then, same as intestine, pancreas is palpated. Because it's parenchymatous organs, but it also resembles flat cylinder, and we can palpate pancreas through its upper to lower part. But pancreas is palpated in 3 projective points. Projection of its head in pancreatic points. Its points along course of rectus muscle will rise head of patient, palpate 8 of rectus muscles, lie down please, and then rise from the navel on 5 centimeters. It's pancreatic points or projection of pancreas head. Symmetrical only to the left, Kacha point of pancreas body, and crossing of this line with rib will be tail point, 3 point of pancreas. Head, body, tail. Then we'll put our hands such that third finger will be in projective point. Then make fold, deepen movement, 2, 3, and then sliding movement. And again, body, third finger in Kacha point, next finger on one line, position, fold, then deepen and sliding movement. Same tail, position, fold, deepen and sliding movements. Normally pancreas impalpable because its consistency resembles consistency of subcutaneous fat. It becomes palpable only when it changes consistency, becomes formed due to tumor or sclerosis. Other organs must be palpated with different methods. We'll exclude sliding movements. We'll palpate parenchymatous organs with 3 movements: position, fold, deepen, and stop. After that, we must ask patient make deep inspiration because all organs lie near the diaphragm, immediately under the diaphragm. And we'll ask patient make deep inspiration, during which lung moves downwards and push on underlying organs. Organs move downwards to our end. And normally all these organs impalpable, instead liver. Liver can be palpated if the patient without subcutaneous fat or if the doctor has necessary vertical skills. Liver palpation. Firstly, we'll determine its position. We'll percussion on mid-clavicular line from iliac bone to rib arch. Position of layer above rib arch. We'll put our finger such that third finger will be along mid-clavicular line, slightly lower rib arch. Lower 1-2 centimeters. Left hand must press rib arch because we'll prevent lateral movements of liver. It's needed that liver moves only downwards. This is initial position. And on contrary from hollow organs, when position of hand will be rounded, and finger also during deepen movement gradually rounds inside the abdomen. This will put our palm flatten. This is initial position. Then fall downwards. Then patient make inspiration. During expiration, we'll move under the rib arch with 1 movement because liver lies superficially. And then we'll ask patient make deep inspiration, but our hand unmovable. I'll wait liver. Because if I'll move hand, my hand moves from the organ. we must give the patient two different commands. Firstly, patient breathes with abdomen, usually. Then, after deep in movements, he must make deep inspiration. Gallbladder, gallbladder. Also palpated as liver. Firstly, we'll determine position of lower body of liver, because gallbladder lies on the liver and it moves together with liver downward. But position of right hand slightly medially from mid-clavicular line. Left hand again press rib arch. We'll put finger slightly lower rib arch, make fold. During expiration moves under rib arch, and again ask the patient make deep inspiration. Deep inspiration.
Gallbladder cannot be palpable.
Cannot be palpable. Cannot be palpable. But in this patient is palpable lobe of liver. If you want, you can palpate. Very elastic and very small. No, it's normally along parasternal line. Leaf can be displaced below the rib arch 2 centimeters, and it's palpable. Kidney lies deeply. Left hand will put under the loin, and during palpation will make rising movements. We won't push the kidney upwards, because they lies very deeply behind the peritoneum. Put the left hand under the loin. Right hand also near the rib arch, but slightly laterally from mid-clavicular line. Position for liver, gallbladder, kidney laterally. Again make fold, but we'll make 2-3 deep in movement, on contrary from liver and gallbladder. And during inspiration we'll make 1, 2, 3 deep in movement. Then as the patient make deep inspiration, our hand unmovable. Kidney impalpable in movement. If is needed palpate other kidney. No, if our patient thin, we can put left hand such under through the loin, and position will be same. If the patient sick, we can put right hand under the loin and palpate with left hand, or palpate left kidney with erect position. Spleen. For palpation of spleen, patient must be placed on right side. Lies on right side. His hand must be placed under the head. Left leg must be bent. We maximally relax left side both hands. Then palpation resembles liver palpation. We'll press rib arch to prevent lateral movements of spleen. Right hand perpendicular of rib arch. We'll make fold. Then during expiration, one movement under rib arch, and then as the patient make deep inspiration, our hand unmovable. Spleen impalpable. That's all. Percussion. We'll determine size of liver by Kurlov, by Abrazov, and size of spleen. And size of spleen. Give me a pencil. Size of liver by Abrazov will determine along anterior axillary line, mid-clavicular, and parasternal line. All size vertical.
Anterior axillary.
Firstly, anterior axillary line. Sound change will make mark. Then from down. Sound change will again make mark. Then along mid-clavicular line. Finger must be placed only in interspace. And symmetrically from down. Then along parasternal line. that normally lower body cannot be displaced below rib arch. You see that it's on the level rib arch. Along parasternal line, it can be displaced 2 centimeters, as in our patient. Then we'll take scale, give me the scale, and measure all distance in centimeters. Along anterior axillary line, along mid-clavicular line, and along parasternal line. 3 vertical sides, which characterizes only right lobe of liver. Kurlov help determine right and left lobe. We determine position of liver along mid-clavicular line, we have mark. Then along linea mediana anterior, this is line. But this line moves through the sternum, will not picash over the bone, will transmit upper mark on the sternum and determine only lower level. Same level. And determine only lower body. And make. And then will picash third size along rib arch. We'll start from the xiphoid process and finger gradually moves along rib arch. Before tympanic sound, because it will be Traube space. And then we'll measure vertical distance along mid-clavicular line, vertical distance along linea mediana anterior, and incline size along rib arch. 3 size by Kurlov. Size of spleen. Patient can lie on the back or on the right side. And will picash spleen along mid-axillary line. Firstly, along mid-axillary line. Upper body, and then continue its lower body. Normally it must be between 9-11 ribs, or must be 4-6 centimeters. Then will picash from mid-axillary line along rib arch, firstly to the right, and then again from mid-axillary line to the back. Make mark and measure longitudinal size. Now, in our patient, transverse sign is 4 centimeters, longitudinal size is 10 centimeters. It's normal spleen. Then tenderness point. Tenderness point of gallbladder. Firstly, gallbladder point, it's crossing rectus muscles with rib arch, this point. And when we'll determine point, we must press only with one finger, Then, next point is phrenicus symptoms. We'll press between branches of sternocleidomastoidous muscles. We'll turn neck of patient, find both neck and put finger between on the claviculas and symmetrically to the right. And simultaneously press above the claviculas. When we'll determine symmetrical point, we'll ask the patient about his sensation. Patient must symmetrically feels our pressure. If patient feels asymmetrically, it indicates pathology. Then acromion point. This is point connection of clavicle with shoulder. Also press symmetrically. Then sit down, please. At the back or sit down, please.
Ma'am, phrenic symptoms must you do if we lie down, ma'am.
You can lie down or sit down, it's not significantly. At the back, stand up, please. At the back, we'll press on Scapular angle. No, in our patient, scapula slightly separated from the chest, yes? And we easily feel scapular angle. If the patient with obesity will find scapular angle with palpation, such method. This is scapular point. Scapula covers 7 ribs. Paravertebral point is determined from 9 to 11. We'll move 2 vertebra lower and press on spine vertebra from 8 to 11 vertebra. Paravertebral point. And then we'll determine Zaharin head zone. Put finger Zaharin head zone. 11, 9, 10 interspace from anterior axillary line and palpate along interspace to the linea mediana anterior. Such movement. And again, ask the patient about symmetrical sensation. Like this. Points of pancreas, tenderness points of pancreas. Resembles points in gallbladder, but instead point of gallbladder will determine points of pancreas. It's Haledaha pancreatic points, Kacha points, and tail points. Next points, same. Acromial, phrenicus, scapular, paravertebral, Zaharin head point. But in gallbladder diseases, sensitivity increases to the right, in pancreas diseases to the left, Syndromes of gallbladder, pressing and tapping. Pressing syndromes. All symptoms must be determined in projection of gallbladder, crossing rectus muscles with rib arch. But syndromes we can determine with 2-3 fingers. Points only with 1 finger. It's significantly. Firstly, pressing syndrome. We'll press in this point, ask the patient, make inspiration, and ask about pain. It will determine syndrome Kera and Murphy. We'll press 1 time, press, and then patient make inspiration. Because during inspiration, gallbladder tightly pressed to our finger. And if present inflammation, pain increases. If pain increases, it will be Kera positive. If pain increases such significantly, the patient cannot finish inspiration, it will be Murphy. If Murphy positive, it indicates acute pathology, acute inflammation. Chronic inflammation can be only Kera positive, or it depends from activity of nervous system, because we'll feel pain differently depending from level of our nervous system. Tapping syndrome. Firstly, we'll Percussion over rib arch, projection of gallbladder and symmetrically to the left, and ask the patient about symmetrical sensation. Or we can Percussion along right rib arch. Again, ask about symmetrical sensation. Both methods. It will be Ortner symptoms, symmetrically right, left, or along right rib arch. Only one method can be used. Then, syndrome Le Pen will Percussion over projection gallbladder. Ask about pain. Then Vasilenko, ask the patient make inspiration, and again Percussion over projection. This is tapping syndrome of gallbladder. Points of kidney. 1 point in crossing rectus muscle with free end of rib. Rectus muscle with free end of 11 rib. 10 rib is formed rib arch, but 11 and 12 ribs are free, yes? Crossing 11 ribs. This is one kidney point. Other kidney point at the back. No, I'll show later. Then anteriorly we'll determine ureter's point. 1 point along rectus muscles on the level of navel, right and left. Next point, crossing rectus muscles with ilioinguinal bone, also right and left. It is ureter's point. Along rectus muscle, 1 point on the level of navel, other point crossing rectus muscle with ilioinguinal bone. At the back, stand up, please. Crossing musculus latissimus dorsa with 12th rib. This is left and right. Crossing musculus latissimus dorsi with 12th rib. No, it's symmetrically anterior point. This is kidney point. And for examination, patient with kidney disease will use Pasternatsky symptom. One hand will put such that it will be crossed by 12th rib. Can be vertical or can be horizontal position. And then tap one and other side. Ask the patient about pain. It's modified Pasternatsky symptom. Because through Pasternatsky symptom we must collect urine before, then tap, again collect urine. If amount of erythrocytes increases, it indicates positive Pasternatsky symptom. But with this syndrome it becomes short and can be determined immediately without laboratory. Yes, part of stomach, which lies above the rib arch and below the lung. It's needed to determine left hydrothorax, because X-ray examination reveal hydrothorax only if amount of fluid more than 500 milliliters. If smaller, it cannot be revealed with X-ray examination, but we can reveal it with physical examination. We'll determine right body.
500 milliliter.
500 milliliters, half liter. Half liter. Right body, left body and upper body. We can start from right and left. Percussion along rib arch from xiphoid process. From dull sound because it's liver. Before tympanic sound and make mark. Then continue before new dull sound. Because it's spleen. This is right and left body. Then we'll put finger on rib arch and percussion upward on the distance medium between right and left mark, parallel of rib arch. From tympanic to lung sound, make mark. When we'll interconnect 3 points, we'll have traube space. Lower body is formed by rib arch.
This one along the rib arch, ma'am.
Along rib arch. First along rib arch. From liver to spleen, between present stomach. And mobility of lung, mobility of lung. Mobility of lung indicate, I'll show at the back because many mark anteriorly. Yes, we'll determine mobility along mid-clavicular, mid-axillary and scapular line. I'll show along scapular line. Firstly, we'll determine normal position during normal breathing. Sound dull, I'll make mark. It's normal position of lung. Then I'll ask patient make deep inspiration and hold the breath. Make please deep inspiration, hold the breath. Lung moves lower. Breath please. It's new mark. It's maximal expansion of lung. Then I'll turn on initial level and ask the patient make deep expiration and again hold the breath. Make please deep inspiration and hold the breath. I'll percussion from dull sound to new lung sound. Breath please. And make again new mark. Then I'll measure distance between upper and lower mark. It's mobility of lung. Or possible of lung, use additional possibility if needed.